I think we're going to get started in the interest of time here so we don't get too far behind. And I want to thank all of our online participants. Thank you for being with us. And we're monitoring the chat, and you can put your questions in there and we'll be happy to answer them. You know, one of the crosshairs in women's health and all human health is medications. And many of us have to be on medications for various reasons. And we thought it would be really important, and we had people actually ask us to have a discussion on this, on, you know, what happens with medications in women as opposed to men, and how can we use these pharmacogenomic tests that are being done on our patients to understand their medication sensitivities and address drug outcomes in women's health. And so, of course, we asked the best in the world, which is a panel here from the University of Utah, Dr. Diana Brixner, who's professor in the Department of Pharmacotherapy and is the founder of the Pharmacotherapy Outcomes Research Center, or PORC, here at the University of Utah. This is a big deal. She's also the past president of both the Academy of Managed Care Pharmacy and the International Society of Pharmacogenomics and Outcomes Research. And joining her is Dr. Joseph Rauer, who's a board-certified clinical pharmacologist, and he's a research assistant professor in the Department of Pharmacology and Toxicology, and is a co-director of the Center of Human Toxicology. And he really is focused in on personalized medicine tools, especially also in pediatric dosing. And also Dr. Ryan Nelson, who is the medical director of precision medicine, an adjunct professor here at the University of Utah, and he really applies precision medicine in pharmacology. So I want to thank you all three for being here, and I'm going to turn this over to Dr. Brixner. This is the slide advance right there.
All right. Thank you so much, Kathleen. It really is a pleasure to be here and talking with all of you. I solicited 2 men, so we increased the percentage of men that are actually at the program this afternoon. So thank you both for coming and speaking with us today. To start our session, I wanted to ask 2 questions to kind of ground us as to how much are we actually exposed today, everyday, daily practice, to pharmacogenomics and treating our patients. So 2 questions. One is, how many in the audience have actually requested a patient to go and get a pharmacogenetic profile for themselves, for their patient? 2. This is great. Of course, you 2 don't count. Yeah. Okay. So a few. Let me ask part 2. How many of you have had a patient come in with a report in hand of their test results and asking how that would impact treatment? Interesting. So it's about the same, right? So I'm going to say the majority of the rest of you, not so sure whether you should request it or not for your patient, and you're not seeing your patients actually come in with the results. My prediction is over the next 5 to 10 years, the number of you that would raise your hands when I ask those 2 questions are going to increase exponentially. And so we're excited today to give you a little window of the world and around why and how that may happen. So we only have 25 minutes, so we're going to go through kind of quickly our 3 main agenda items. The first is, what is pharmacogenetic testing and why should you care? Why does it really matter? A few comments, introductory comments for myself. I'm then going to hand it over to Dr. Rauer to talk about how the results of these tests can impact drug outcomes. Again, to give you some real world examples to show you biologically how this works and how this happens. And then we're going to have Dr. Ryan Nelson close us out on understanding a little bit what's very important is operationally. How exactly are these tests ordered? Even more intimidating is that when these results come back at you, How are you supposed to interpret them? What do they mean? And then how do you actually put them to use in the decisions you make on how you're going to treat your patients going forward? And in the hopeful time that we have left, we're going to have a few questions to ask these two, as well as the audience, to provide any input and feedback. So, very brief in a nutshell, what is pharmacogenomics? It's really a combination of two sciences. One, pharmacology, the science of how drugs work in the body, as well as genomics, the science of how genes work in the body, hence the name pharmacogenomics. If we look at precision medicine, what does it really mean? Well, precision medicine is trying to get more precise about the drugs you're prescribing for your patient in treatment, and you're doing that by biomarker-guided therapy. So in other words, by understanding the DNA, the RNA profile, protein profiles of your patients, you can improve the therapeutic process. You highly increase the likelihood that your patient is going to react appropriately to a certain treatment choice. Pharmacogenetics, pharmacogenomics, two terms that I don't always get the definitions of each straight. So for you all, the pharmacogenetics means you're talking specifically about a gene and a drug pair, more precise. Whereas pharmacogenomics is broader, it's looking at multiple genes combined that influence pharmacotherapy choices. Now, why is it important? What does it matter? Well, there's two components here on this slide. Kind of my entire career of research is looking at value in pharmaceuticals. How can you increase the quality and outcomes for patients and do this while reducing overall costs for the patient and health systems? Well, pharmacogenomics impacts both sides of the equation. As far as reducing cost, if you get a more accurate treatment that works more quickly and appropriately for a patient, ultimately you're going to reduce total patient care costs. You prevent adverse events, and you'll hear from our other two panelists exactly how that happens when you apply pharmacogenomics to therapeutic decisions. You avoid pharmacotherapy visits that aren't necessary because, again, you have more precise treatment choices. And you may mitigate CMS performance penalties by, again, getting the right drug to the right patient at the right time using pharmacogenomics. Now, on the other side of the equation, it also increases quality. You can expedite time to treatment success, beneficial to you, beneficial to patients. Increase patient safety and satisfaction, optimize provider patient time use, and also improve clinical efficiency and efficacy. All positive outcomes. So, in conclusion of my introductory comments, what are some actual clinical applications? Well, related specifically to women and breast cancer, it's one of the most common disease areas where genetic testing is actually used to tailor chemotherapy regimens based on individual responses. A very famous example is a test called Oncotype, which will predict how a woman will react to therapy to prevent reoccurrence of their cancer. So in other words, if you see a genetic test saying that you will respond and this does decrease your risk, you know you're making a good decision for your patient. If the results show that this patient is actually not going to respond to the treatment, you're sparing that woman from being exposed to unnecessary chemotherapy of which she's going to get no benefit, but yet will still suffer all the adverse events associated with that chemotherapy. Hormone replacement therapy. Genetic variants for each of the women that you would treat are influenced by hormone metabolism. So therefore, testing, understanding genetic profiles can really provide guidance into appropriate hormone therapy choices. And then a broader application to certainly both men and women, but many women are exposed to cardiovascular medications. There are a lot of genetic variants that affect drug metabolism of many cardiovascular medications, and that therefore a personalized design can improve outcomes and reduce adverse events and costs. So that's my brief introductory comments. With that, I'm now going to hand it over to Dr. Rauer to go into some of the results and impact on outcomes.
Thank you, Dr. Brixner. Okay, so I definitely come more from the pharmacogenetic side of things. I take kind of a targeted drug gene kind of investigative approach. So I'm going to talk mostly from that perspective. So, and distill a semester of graduate school down into one slide. So I apologize if it's a little dense. What is a single nucleotide polymorphism, or a SNP? It's a change in a nucleotide base pair within your gene, okay? And what we all know about genes encode amino acids build proteins. And so if you change a gene, you might change an amino acid, which might mean that you change the expression or function of a protein in the body, okay? The way we determine if an individual has a SNP of interest is we take a sample, be that blood or saliva or buccal swab. We take and we isolate and purify the DNA in that sample, and then we amplify it in solution with probes that either have the wild type gene or the variant gene of interest, and then we tag those probes with fluorescence, okay? And essentially what happens in a quantitative polymerase chain reaction, or qPCR instrument, is it will amplify your DNA, add one of those two probes depending on what DNA is present, put fluorescent tags on there, and then you can actually quantify whether an individual is a homozygous wild type individual, which you can kind of see in, if I can get the laser pointer here, you'll see like a cluster here that's homozygous wild type, heterozygous, so meaning they have both the wild type or the kind of common or ancestral allele, and a variant, or they might be homozygous variant. And what that tells you is a little bit about drug disposition. So what the drug does once it goes into your body, how it gets absorbed, how it gets distributed, metabolized, and eventually excreted from the body, okay? One thing we know is that there are a lot of proteins in the body. I don't think that comes as a surprise to anybody. But about, oops, let's not hit the forward button, let's hit the laser button. There are about 75% of drugs that are commonly prescribed are metabolized, okay? Most of those, about 50% of them, are metabolized by a protein called cytochrome P450, or one of its isoforms, okay? So that's a large number of drugs that go through this one enzyme, this enzyme that we know to be highly polymorphic. And so if there are changes in the genes that encode that enzyme, there's likely to be changes in the expression or function of that enzyme. And as a result, you might get a change in either drug concentrations you see in the body, or eventually the effect of the drug on the disease you're trying to treat. Importantly, in the sense of this symposium where we're looking at women's health, you can also have polymorphisms within drug transporters that help get drug from your stomach, say after you take it orally, into the body, into the bloodstream, and into certain tissues of interest. One that might be particularly interesting here, so we have drug transporters called P-glycoproteins, which actually prevent drugs or certain xenobiotics from getting into places. They're efflux transporters. They kick drug back out of tissue. They're highly prevalent in the placenta, and also known to be polymorphic. So there's a risk, depending on what polymorphism you have, that you may actually, if you're taking a certain drug, predispose the placenta and fetus into potentially having higher exposure to a drug that would otherwise have been efflux by PGP. So some classic examples of kind of SNP gene drug pairs that we like to think about here. The most common one that I think about is this metabolism of codeine into its active form, morphine, okay? That's mediated by cytochrome P450 2D6. Again, known to be polymorphic. For some individuals, the polymorphism that they carry says that they are a poor metabolizer of drugs through the CYP2D6 route, okay? So if you're relying on codeine being transformed into morphine through CYP2D6, and the person can't do that, they're not going to get any analgesic benefit from codeine therapy. On the flip side, you could have a SNP that says you're an ultra-rapid metabolizer, in which case they break codeine down very rapidly to morphine. You actually get to a point where you have too much analgesia, potentially an altered state, and in extreme examples, you get to potentially respiratory distress. So you go from no efficacy to too much efficacy and toxicity. So that's why it's kind of an important concept to think about, depending on the drugs you're prescribing and depending on the genes that might interact with that drug. When we think about this in women's health, two kind of key ideas or key examples popped in my mind. One being estrogen metabolism. That is mainly done by cytochrome P450s, which, as I've already mentioned, is highly polymorphic. And so depending on what polymorphisms you have, you might have different metabolic profiles of estrogen, which obviously can impact a lot of things. And then Dr. Brixner mentioned kind of the breast cancer side of things. So one of the compounds we use to treat breast cancer, tamoxifen, actually has to be activated, kind of like our codeine to morphine story, has to be activated by cytochrome P450 2D6. And so you have the same sort of idea where some people who can't activate tamoxifen into its active form don't get any benefit from the drug, whereas some people may require a dose reduction to avoid any unwanted toxicity from the drug. And so to kind of transition this more towards Dr. Nelson's expertise, kind of a brief talk about how this actually gets implemented in the clinic. Several companies now actually have genetic tests where they will go through, they'll take a sample and they will provide a report, as some of you have mentioned that you might have seen in your clinic, that walks through all the known kind of drug gene pairs and provides advice based off an individual's genotype for that gene of interest. The unfortunate truth of this, though, is that in order for this to get covered by insurance, to actually get utilized by the clinician, we have to have a lot of knowledge and a lot of evidence to prove that that drug gene pair should be implemented clinically. And unfortunately, our knowledge about the importance of this and our knowledge and evidence supporting specific drug gene pairs aren't always concordant. And so there's, definitely a little bit of lag in the evidence compared to what we think we can do within this field. There are definitely success stories. So if you go to, PubMed and search for CPIC guidelines, Clinical Pharmacogenomics Implementation Consortium, CPIC, you can find, it doesn't roll off the tongue very well, sorry. But you can definitely find guidance for some drugs in the literature that say, kind of like the table that I've shown here for tamoxifen, here's what to do based on a genotype, here's how to dose this individual based on a genotype. A story from my own research, so we found for tacrolimus, which is an immunosuppressant used following pediatric heart transplant, that people who express the main enzyme that breaks down tacrolimus, these children actually required a 2.7-fold higher dose than children who don't have that enzyme, who don't express that enzyme based on their SNP. And that's pretty significant when you're talking about a drug that has a very narrow therapeutic index or difference between an effective concentration and a toxic concentration. And so fortunately, based on this research, we were actually able to convince the pediatric heart transplant team to start genotyping these kids before transplant to improve dosing immediately after transplant and hopefully get them to the right dose a little bit quicker, treat them better. And so with that, I'll transfer over to Dr. Nelson.
So before I talk a little bit about implementation and some of the outcomes, the first thing that I really want to use as a use case argument here is 4 data points from a study that was done by the Kentucky Teachers Retirement System, where they took a little over 5,000 patients in the observation arm compared to a control arm. It was about 4-fold higher. And they had a clinic where medication therapy management by pharmacists looks at the overall profile of medications that a patient is taking and then tries to tailor those medications to not have drug-drug interactions or in some cases, drug-gene interactions. When they did this study, they had one arm that did genotyping and one arm that did not. The 5,000 were the ones that had genotyping done. And by considering their genotype and trying to alter pharmacotherapy accordingly, they found a 6.8% reduction in emergency department visits a 15% reduction in inpatient encounters with these individuals within the cohorts, and a $218 per member per month savings. That led up to $37 million of savings over 32 months. This is not insignificant money. And behind that money are actual untoward effects that we oftentimes are blind to their actual correlates or contributions from genotype versus gene-drug interaction compared to drug-drug interaction, or if it's a lifestyle or adherence thing. The thing that I think is important to note about this is not just pharmacogenetics that is going to be the only thing that matters in what you're doing with your pharmacotherapy decisions, but it is one of many tools that clinicians at large need to collaborate in order to integrate into decision-making. Now, there are a few hands that were raised here that had a pharmacogenetic test brought to them. Can you raise your hand again? May I ask just what the clinical settings were real quick? What kind of patient and what was happening with them?
The SIP system. Mainly.
And what were they being treated for at the time?
Migraine.
Okay. Depression and migraine. So both SSRI related decisions, which there's quite a bit of data behind for helping at least not select certain SSRIs. Did you guys know at that time what you wanted to do? And it's totally okay if you didn't, but when they handed that to you, what was your immediate reaction?
I went, how do I interpret this?
Was it just a piece of paper that they handed you or a PDF?
Like several pieces.
Right.
Like this thick.
And you've got what? You got 10 minutes maybe to speak with this patient? And right? And you're wondering, now that this thing has been brought into my life and I don't know that much about it, what do I do? Am I liable for this information that's now been put in front of me if I make the wrong decision accordingly? And you start to feel all these feelings of anxiety, uncertainty. What does this test actually cover? Is this a reliable test? There's tons of things that I think we still have some pretty big hurdles around to try and consider what to do. I did not put this slide up because I want you to write this down. Clinical Pharmacogenetics Implementation Consortium, or CPIC. If somebody comes to you with a PDF and says, here, what do I do? That's the place that you go. And if it is not a guideline that is listed there, not 100% fidelity here, but close enough, there's likely not to be evidence that is robust enough to support you making a difference in your clinical decision-making, although there may be data of lesser support to help inform some decisions. Reliable, robust clinical data on what do I do if a patient hands me a genetic test report with cytochrome P450s and a few other drug metabolizing enzymes are going to be best found there. They have some very abbreviated and simplified tables that are very clear on what the genotype is, what the predicted phenotype will be because of that, and what ramifications that then has on the decisions that will be made for that patient according to their genotypes. And if you don't have confidence there, you can call me or email me. I'm more than happy to help the University of Utah, and I do so with the Supportive Care and Oncology Survivorship Clinic, or SOS Clinic, up at HCI. I love curveball cases that get really difficult and bring in more than one pharmacotherapy case that you're trying to do. So I don't have all of the time in the world, but Ryan.Nelson at ARUP Laboratories, please email me. I'd be happy to help you. The thing that I think is important here, though, is being comfortable with not being certain on what you're trying to do and then figuring out resource-wise where to go next. And, just for the sake of how limited time you guys already have with these results, CPIC is the place that you want to go. And if you can't figure it out there, you can email me, another person within your informatics department at the University of Utah. He's going to probably hate me for referring him. But David L. Halta is a pharmacist in the informatics program here that has done a couple of best practice alerts that if you guys feel strongly within your clinic, you're seeing something in a repetitive fashion, could do an implementation project for a BPA to fire if you would like it to within your clinics. But I think that's the main thing that is important as far as results. The part about ordering, so at the U, you guys do a lot through ARUP. We offer, I think, the most competitive pricing and, in my opinion, one of the most robust tests available for pharmacogenetic testing. And from there, we can then deliver discrete results into the EMR that you can build BPAs around, as well as a static PDF in order for you to refer to and interpret. So whatever preferences are really had, we can support whatever it is that you would like to have done there. But with that, I think that's everything that is important to emphasize here for the University of Utah. For others, there's plenty of other pharmacogenetic tests. The thing that matters is that it's CAP accredited, the College of American Pathology. Their accreditation really matters for pharmacogenetic tests. Oh, yeah. CPIC, and that's Clinical Pharmacogenetics Implementation Consortium.
It still doesn't roll off the tongue.
It doesn't. CPIC, though, does.
So I apologize, I kind of wrapped up.
After, if you email me, I can get you a whole slide deck.
So I predicted this was going to happen. We're going to run out of time, which we'd have. And in respect to the rest of the program, I am going to turn it over now back to Kathleen. However, I did want to at least put this slide up here on some of the discussion topics and things to think about. Most of all, how do these test results impact prescribing in women's health? And I think what I'd love to do is perhaps do a little research. If I think of all of you in your practice, you'd want to walk away with, what are the main areas that I maybe should be thinking about whether this type of testing should be done or not? And I think, it's antidepressants, it's migraine, and like, what are the top prevalent diseases in women that have the top prevalence of drug metabolizing enzymes? What's that cross? And is there a paper out there, one paper that kind of summarizes that for women's health that maybe we could share after the program with everyone?
That would be great.
Okay. All right. And with that, I thank you so much for your time, and I'll turn it back to Kathleen. Okay, so we had apparently time for one question. Any burning questions from the audience? Yeah. Michael.
I don't know if it's burning or not, but for all of us, our circulating levels of estrogens and androgens are going to vary over the lifespan. And how much, if any, do those levels affect epigenetic effects of SNP testing?
Great question, Joseph. I think I'll defer that to you.
Use the mic.
Yeah.
I'm not sure I have a great answer. So, unfortunately, I'm not sure I have a great answer. I mean, your SNPs will be predetermined at birth, right? So that won't be changing. I mean, epigenetics will be changing based on diet, environment, all those sorts of things. How that directly affects estrogen, I'm not entirely certain of the literature there. So unfortunately, I don't have a great answer. Sorry.
Conceptually, though, it's a good question.
Yeah.
Right. How does that change, and how does that impact SNPs?
Highly variable.
Okay. Yeah.
Yeah.
That would have been a good, safe answer.
Yeah.
Yeah.
It's other burning questions.
Yeah.
Because this is such an important area in women's health, and for providers, it's like critical.
It will continue to change. So,
Yeah.
Thank you.
Thank you so much. Great